I just got a page about bed 20. I think it's, oh yeah, did you do an ECG? Or if not, can you just do one real quick? Yeah, if that's all right. I'll come and look at it once it's done. Cheers. Bye. Yeah, look, I think that's actually a pretty good learning point, to be honest. I mean, you'll get pages from the nursing staff sometimes who actually know the patients really well, and there might actually not be that much of a clinical change. Like this patient just got paged because they had a low heart rate. It was heart rate of 55. They said that he's previously had some sinus bradycardia. It was asymptomatic and there was no concerns. And they just wanted a modification because usually heart rates are between 60 and 100. So if it drops below 60, then you need to actually investigate it or modify the range to say that that's fine if there's no other cause that is sinister or you're worried about. And I mean, you get paged like this just asking to alter the criteria straight away, and you actually skip a whole lot of the whole clinical evaluation. And sure, it doesn't need to be, exhaustively investigated if you know the patient and there's been no clinical change and it's very similar. But if you're unfamiliar with the patient, you actually need to go in and do the proper full workup. So I'll go and see this person, I'll get an ECG, I'll see if there's any changes compared to the earlier ECGs that were done earlier in the admission. But I won't just simply alter the mods, alter the reference range for the heart rate because I'm told to do so. And I think that's a trap for young players. I mean, you can get in the habit of just doing what people ask you to do, but you need to be able to think for yourself and think, well, does this, hold up medically, medico-legally, and also logically, am I actually doing the right thing systematically, going through the full workup of the patient? And sure, it might seem a little bit innocuous, this heart rate issue, this mild bradycardia, and it most likely will be, unremarkable and won't really change anything that we're doing. But you need to dot the I's and cross the T's to make sure that there's nothing else going on. And just from a medico-legal standpoint, you should actually, if you don't know the patient, fully work them up and go through all the possible causes of everything like that. So yeah, there may actually be no change, but if you don't know the patient, you can't assume, and you're actually the medical professional making these decisions. So if anything goes wrong, you're on the chopping block. So you need to look out for yourself and actually do proper medicine. Don't just take shortcuts the whole time. So yeah, I mean, that's an interesting one to start off the shift. Yeah, it's been pretty touch and go. I mean, we still actually got to admit 2 patients, and one is for the orthopedics team and one is for the plastics team. So there was a broken ankle, I think, and then there was a dog bite that needs to be repaired in theatre tomorrow. So yeah, it's been pretty busy, to be honest. There was a couple things I had to chase, a couple things that I got handed over, so we're slowly making our way down that list. There's still a few patients to review. They have actually gone outside for a smoke, funnily enough. So, we don't allow people to smoke in hospital. We encourage them not to smoke at all because it actually does way more damage than you would ever think. And especially surgical patients, it affects wound healing and recovery and just their whole, post-op period where they're trying to get better. But if they're smoking, you're actually sort of prohibiting all that healing and all that good stuff from happening. So you want to supplement their craving with nicotine patches or lozenges or some sort of nicotine replacement therapy. Just these 2 patients where I wanted to review them, they had both gone outside for a smoke. And I mean, if I couldn't stop them, and I'm not going to go outside the hospital to chase them down and tell them to come back and do something else. But yeah, I mean, when they get back, I'll see them and offer them some of those other things like a patch or something like that. But yeah, it's a funny one, smoking in hospital. You definitely cannot smoke in the ward or at the hospital location at all. But if people do smoke, I mean, you can't say completely go cold turkey. Otherwise they get withdrawal syndromes.
So you need to replace it and then advise cessation or stopping smoking or whatever, drug they're, currently taking outside hospital once they're discharged, because you can't do everything in the inpatient setting. So just put band-aids on it, put the nicotine replacement therapy in, and then once the patient's healthier and improved, then start thinking, all right, how can we actually wean this patient off that medication or wean them off that drug so they can actually live like a healthier life. So we've had to just review these patients. We have admitted, we were going to admit that patient, but then they went outside for a smoke, so we're going to admit them now because I think they're back. And then there's a second patient with a broken ankle who needs a reduction, and then I'll go and admit them. So yeah, before that, then we went to a huddle. So that's the huddles where you meet all the doctors for the night shift, the medical doctors, the lead doctors, the bed manager, the ICU liaison nurse, who is essentially the nurse who comes to all the MET calls and everything like that. So yeah, and all the code blues, and they act as a bridge between the ward and then the ICU, the intensive care unit, where they send the sickest patients. So yeah, what else did I have to do? I had to coordinate a patient for theatre to see if they were still going ahead to theatre. So you call the bed manager. You don't call the bed manager, you call the theatre nurse in charge, and then you also confirm that plan with the registrar of that surgical unit, because yeah, sure, there might be a plan to take them to theatre, but if there's no person operating, then there's no theatre. So confirm with the nurse in charge that they're on the list for the operating table, and then also confirm with the surgeon who's doing the operation to make sure that they are actually still planning to do the operation, or if they're going to wait for tomorrow. So yeah, it's actually been pretty busy, to be honest. We're going to get some coffee real soon, which will be nice. I think one of the senior doctors is buying the coffee, which is super, super lovely. And that'll keep our energy up. Although I do sort of want to sleep, so should I have the coffee? I'm not sure. Yeah, because I'm only on this shift for tonight, and then I'm back to normal day shifts after that. So yeah, but right now what we're doing, it's about 10:30 p.m. We're going to review these patients and admit them because they've been accepted under specific units at the hospital. I'm going to get the coffee, and then I'm going to come back here. Yeah, got you. Yeah. Can I just say, that was actually quite busy. For the past few hours, we've actually been absolutely chockers. We had almost 3 admissions to do. Well, I was planning to do 3, and then some things just pan out. They actually just work out if you just leave them alone for a little bit. It's like a funny thing in the hospital. So you notice this when you keep working in there for quite a while. And sometimes what happens is that an issue will come up and people will alert you about the issue. And then if you immediately drop everything there is to do and just focus on that next issue, then you actually will create more work for yourself sometimes. Now, here's the example. So this patient was going to be admitted under the orthopedics unit. They had a broken ankle, and it was a dislocated ankle that needed to be reduced. And essentially what the plan was from the ED doctor was for me to come and admit them. They'd been accepted by the orthopedics doctors, and essentially they needed to have a reduction via some procedural sedation. So essentially that means they give them some medications to make them a little bit less conscious, and then they can move the bones back into place, a reduction, without the need to put them fully to sleep with an anesthetic agent. So that happened, and then the plan was to come in and stay in hospital under the orthopedics team. And what I was going to do was go and admit them, go and see the patient, review them, and then write up the admission note. What actually happened after that? So the patient had undergone that procedure, the reduction of the fracture, and then the orthopedics doctors reviewed the patient and the plan and said, well, if after that's been done, the patient's fine,
they can actually go home and then they can get seen in the outpatient setting in the clinic. And if the x-ray after that procedure had taken place was fine. And I was reading this note thinking, well, I actually don't need to admit them, because if the x-ray is fine, then it's all been sorted out by ED and the orthopedics team. I don't need to do anything. So I just did another admission. This patient had actually been bitten by a dog, and we needed to sort out their stuff for tomorrow. They were going to go to the operating theatre to get that all repaired. And whilst I was doing that, the ED doctor actually wrote a note, and they had discussed it with the senior ED doctors and, assessed the x-ray. It was fine. The reduction had actually been sufficient. So the patient was actually planning to go home and get followed up in the orthopedic outpatient setting. So, I didn't actually have to review that patient, but if as soon as I got paged about the patient, I went and admitted them, I would have just created all this random work for me that I actually didn't need to do. So I think the thing to take from this is don't just neglect all your work and then wait for someone else to do it. That's not what I'm saying at all. But what I'm saying is if you drop everything that you're doing and focus on the job that immediately comes up, you may actually not be prioritizing your tasks as best as you could. If it's an issue, and if it's a serious issue, it will declare itself and you'll have to sort it sooner rather than later. If, however, the issue is non-urgent and can actually wait for quite a while, I would suggest doing all the other jobs that are way more urgent, that need your attention and need to be done sooner. Then after all that stuff is done, if that issue is still an issue and you still need to sort it out, then I would go and do it and do whatever you need to do. Assess the patient, chart a medication, order a scan, whatever. You can do that after your urgent jobs are done. So, and you'll actually find, this actually happens so often, it's crazy. The job that was actually urgent, that actually came up, an hour ago, that you're now reviewing to see if it's still an issue, an hour and a half, 2 hours later, may actually have resolved itself. And you didn't need to do a single thing. And that is all through job prioritization and triaging. So that's one of the good skills that you can learn when you start working in the hospital. Is learning what tasks you need to do right now, what tasks can wait, and what tasks can actually be left for quite a while. There's a lot of jobs that you can do in the hospital. And if you have this idea that you need to do them all at the same time, you'll actually get nothing done and you'll actually just stress and freak out. There are jobs that actually can be done after 5 o'clock, and that's a lot of the paperwork and documentation and form filling out that is non-urgent. All the outpatient stuff to be organised can be done at that stage, but all the urgent stuff that actually needs to be done within hours, that should be prioritised over that. So yeah, you get better at it over time, and it took me a while to come to this realisation that you actually do not need to get things done as soon as they come up. And you get comfortable having a lot of tasks on your plate, on your to-do list, but doing the ones that matter first and doing the ones that are less urgent later on. And it sounds simple when you say it like that, but when you were in the hospital working as a junior doctor with quite a small clinical library, all these jobs that come up seem like they need to be done right now. And by just leaving them, you feel like you're inadequate, or you feel like you're doing the patient a disservice, or you're not giving them the best care. Whereas, you can't expect to drop everything and have things, happen for you immediately as soon as you ask for something. There was one thing, a patient I just got paged earlier about, they wanted to speak to a doctor,
about what was happening. And I mean, that's like really not a 1 a.m. sort of job. I mean, these sort of things can wait most of the time. So I started some other jobs that were way more urgent. There was some more admission notes and there was some more reviews of patients that I needed to sort out. But then I got a second page about 5 minutes later saying patient was getting frustrated, really wanted to speak to a doctor. And I thought, okay, this is getting to the point now where I should actually act on this page. It's not like, oh, I should keep ignoring it. A page that initially was, non-urgent or not as urgent as something else I was doing has now actually developed more urgency because the situation has changed. The patient has become more frustrated and the nurse has actually paged me a second time. Now I need to review my triaging, my prioritization of tasks. And that's a real skill because I think, if you're in the boat that you think whatever a page was at that time will stay at that same level of urgency, then you can actually get yourself in a little bit of trouble because situations are dynamic, patients are dynamic, and medical conditions or situations can change. And if you're not able to change with them and adjust your level of prioritization, then situations can actually get worse a lot quicker than you actually thought they would. So potentially, if I left this patient who was very frustrated and wasn't really, drinking my coffee. I'm just digesting my coffee. We actually got a little Macca's coffee, which is pretty nice. One of the senior doctors bought that for us, so that was super lovely. I don't know if I really want coffee though, because I want to actually go back to sleep, to be honest. Anyways, but coffee's so nice, so I'm gonna have to drink it anyways. Even though it's bloody ice cold. I mean, I didn't drink it until 2 hours after it got here, so that's very frustrating. But yeah, so what was I gonna say? I think it was about, this patient who was getting more frustrated and I was not going to see them initially straight away. I was always gonna see them and, actually talk to them about everything. But because now the second page, what is going on here? Yeah, because I got the second page from the nurse who was getting a little bit more, it suggested that they were a little bit more worried about this patient and that I should actually act sooner rather than later. And I guess if I would have left that, what I did is immediately call them back and ask to be put through to the patient because I was at a different location in the hospital, and I actually spoke to them and talked about the situation and weighed up the pros and cons and actually just sort of de-escalated the whole situation. It was actually pretty straightforward. But if I would have ignored that again, then potentially the patient might have, kicked off and became verbally or physically aggressive or abusive. Potentially, I'm going to put this on silent. Potentially the patient may have discharged against medical advice, or maybe, other things. Maybe they would have become more agitated and started interfering with the other patient's care and everything like that. So, I mean, you just don't know. If you sort out situations before they get worse, that is always the best measure. Prevention is always the best. But if you are like super busy and you can't get to those pages, then maybe send someone else, ask a friend for help, give some brief phone advice and say, look, I can't chat right now, but if you hold on for the next hour, I will come by then. Then you actually sort of give some ballpark and some future goals that people can look forward to, and they don't feel like they're completely being ignored, but they can actually, think, oh, this patient is considering, but also has other things to do. And then it puts it into perspective, not only for you, but for that patient and for the whole team. We essentially did 2 admissions. We avoided one because that patient is now going home, and we picked up a little cold coffee, which was nice, a little treat for the night shift. And then we looked at some scans, we charted some medication, we charted a sleeping tablet, we charted some fluids for a patient who was fasting, and yeah, that's it. Now we're gonna do some discharge summaries, which are from the day team that I'm usually a part of. We have a few outstanding discharge summaries that we need to get sorted. So I thought, may as well, I've just had a coffee, I'm not gonna go straight to sleep now. May as well get through them and see if we can knock some off and help out the rest of the team. So let's get that sorted, and yeah, you can make the most of some times when there's not too much to do on the night shift and you can actually be productive, but always bear in mind that it's not a time to do absolutely everything. You will have some downtime, but sometimes that downtime is meant to be used for rest rather than, you know, getting as much as you can done. So yeah. Anyways, let's get to it. Well, I think we had about 30 minutes, if that, and had to do another admission, which is a little bit sad, but it happens, you know. This is another plastic surgery admission. I mean, there's been 3 plastic surgery admissions tonight, which has been absolutely insane. But yeah, we did that. We had to chase up on a patient's bladder scan to see if they were actually able to urinate. They actually were, but they've got some high numbers left behind. So there might be some other things going on with that patient that we might need to investigate as an outpatient. And what else? Some patient had maybe chest pain, maybe tummy pain. It looked like it was the same pain since they came in, so we're just doing an ECG and some troponins to investigate that, but the pain's actually resolved, so we'll just watch and wait and see if anything else develops. Oh, I actually need to just chart some IV fluids for that patient as well, so I should do that right now. And it was funny because there was actually a patient in the same area who was actually getting a bit delirious, and they had to call a code grey. Now, a code grey, if you don't know, is essentially when the security guards have to come in as well. It's a silent code, so all the things that are announced over the loudspeaker, you know, like code blues, met calls, code yellows, everything like that. I mean, they're like medical emergencies or medical codes. There's a couple of codes that are not announced over the loudspeaker, and one of those is a code grey. So essentially someone phones up the switchboard or the switchboard, they call a code grey, and they phone up the medical emergency line. They ask for a code grey, and a couple of security guards usually come around pretty quickly to sort that out. And then the other thing that they do is they contact the medical professional to come in. So usually the treating resident or the treating registrar to help out with the code grey. But they don't announce it. You get paged, but they don't announce it over the loudspeaker. So I was doing that whilst I was investigating all these other patients. Couple of admissions tonight. They've all been pretty straightforward plastic surgery patients, so they usually come in with a single issue. They're usually young, fit and healthy, and they don't have a lot of other things going on with them, which is good. Now, the other admissions that can be a bit complicated are like the orthopedics, old people with lots of medical conditions who come in with broken bones or anything like that, and they actually require quite a lot of stabilization or pre-operative optimization so that they're fit for surgery. I guess in the emergency setting there's not a lot you can do, but you can still try to help optimize their conditions as best as possible, and they often have a lot of different things going on with them, so it can be tricky for surgical doctors who are not usually experts in all that. Oh, getting a page. Yep, that was what I was supposed to be doing. So I'm going to chart those fluids for that patient because they're still fasting. We responded to a couple of other pages. I'm wrecked. It's about 10 to 5, and I'm going to try and get a couple hours sleep before the morning rounds start and before the handover changes for the nurses, and then all the pages come in after that. So let's get some rest. I mean, we've managed to get a little bit of rest, which is nice. A couple of admissions that we had to do, and there was a few reviews of patients that we had to do, but all in all, it actually wasn't the worst shift in the world. You always got to think, like, when you have different tasks all happening at the same time, which ones to do first and which ones to do next, and which ones to potentially like just leave for a little bit and they might actually sort themselves out. Or you might, and it's not just like essentially delaying and ignoring those issues. It's essentially watching and waiting, and sometimes that's actually a completely adequate response. All the issues that arise, you don't need to essentially act with something. You can actually, watch and wait and see what happens and changes, because often that will actually give you more clarity about what to do instead of just instinctively, starting a medication or, commencing a certain treatment. Maybe just step back, watch how the condition goes and changes, and that will actually give you more information. So yeah, sometimes that's the best thing, to be honest. I think one of the best things about night shift is the post-night shift feed, and I actually have no idea what I'm going to get for my breakfast this morning. I mean, to be honest, I would love a bagel, and if that bagel shop is open, I'm 100% going to go there to get myself like a really nice feed. If it's not, I'm going to be utterly disappointed, but I'm going to make do with whatever is open, because you need to treat yourself on the night shift. You have done all this work, you've stayed up overnight, and you essentially just need to treat yourself for doing such a good job. I mean, yeah, sure, it's just work and it's just a shift, and yeah, you don't do it like you work all the time, and like, what's different for this one? But every now and then, especially when you do like a big shift or something like that, or maybe you stay overtime for a few hours, if there's no reward at the end of it, you end up feeling like a little bit like underwhelmed and not really, you might actually have some like negative feelings towards the job or the role in the long run if these keep happening over time. So these moments where you just treat yourself, or relax and have a bit of a chill out, or maybe buy yourself lunch or go out for dinner or have a night off study or something like that. These little things are important. So you break up the what seems to be like a big grind. And yeah, if you do that, then I think you maintain your longevity and reduce your levels of burnout by treating yourself along the way and making sure that you actually maintain, your separation from work. Today what I'm going to do is essentially not do that much at all and relax and rest, and especially after such a big shift. And that's really good, because that means that next time I come to work, I'm actually going to be refreshed and rejuvenated and be clear when I want to learn something, or if I'm about to, learn a new skill, or try to diagnose a different patient with a different medical condition. You have a fresh point of view, and you have clarity, so you're not feeling flat and burnt out. Wow, it is getting quite hot. Let's get out of here, and we'll see if we can find a bagel place or something like that, because I would love a little smoked salmon bagel. That'd be amazing right now. So, sad news. The bagel shop was closed. I don't know what I was thinking, but I just had a little bit of hope. But they let me down, obviously, never going there again. We're gonna have to order something. I don't know what I'm gonna order, but it's definitely gonna be,
something good. Person's running with a face mask. That's insane. How can you run with a face mask, honestly? Remember when we used to do that? I mean, we couldn't go outside except with like a mask to exercise. And you're like, what? Like, that's super intense. Like, there was such a fear of getting COVID that, you know, you couldn't even exercise without a mask on. I think you were still allowed to do it, but there was people who were like, oh, I really don't want to, or I'm really worried about getting infected or whatever. So, yeah, but that person exercising with a mask on, I don't even know how I could breathe. I can barely breathe as it is with this asthma. Oh my God. We try to keep our airways open. Got a couple of puffers to help us out every now and then. Now, one thing we need is a bedside table, which I really want to pick up one today. If I'm feeling energized, I mean, that actually might be a good way of staying awake, is to go furniture shopping and to get some stuff. Sad. They looked open as well. Bagel shop. Doing me dirty. Oh well. Treat myself and order something else. We'll catch you guys around. I'll see you next time. Bye.